Welcome, everyone. This is a very, very important session for us. It is very much around communities. It is very much around ensuring that all the high-level targets and the commitments actually translate onto the ground. And we at GCTA have really been pushing for this in a very strong way, that communities have to take the agenda and lead. And with this, we really wanted to bring together a group of people who could actually input into this. People who are affected by TB, who are doing things on the ground level, who understand the realities, plus also people who have more formally engaged into doing the community monitoring as a program in a more formalized manner. So we have Alan from ITPC, who has a lot of experience in the HIV field, doing community treatment observatories. So I just want to welcome everyone warmly, and I want to hand over to my colleague Archana to go forward with this, but wanted to say very, very warm welcome and big thank you to all of us, all of you. Archana?
Yes, thank you, Blessy. Hello, everybody. It's nice to be connected with all of you here. I think to start off with our session today, I will present, give a brief introduction on why do we need community monitoring. So I'll just share my screen. Second. Yeah. So just to start with, I'm just giving a brief highlight of the TB epidemic globally as it is now. This slide or this figure is taken from the report which was launched yesterday. As you can see in the figure, we still have many people dying from TB, 1.4 million. And we still have 10 million people who fell ill with TB, out of which 1.2 million are children. I mean, this is such a huge number that we are looking at it over here. I think this figures is for a disease which is like preventable and curable. And as also you can see that TB is also the leading killer of people with HIV. So prevention is something that which we need to focus on it now. Now, while Priyanka is pulling up the slide, I was just giving a brief highlight of the figure that as it stands now, we still have like the figure is so big that it's like we have 4,000 people dying of the disease, which is preventable and curable. So now to coming to the second slide, this is again about how the COVID pandemic has affected the TB response. Like, as we all know, this COVID has turned our lives upside down, and more so in the case of, you can imagine how bad it will be in a response which was equally not up to the standard. So this again is just to give you an example. I've just taken out a graph from the report which was launched yesterday, just to give us an idea of how badly it is affecting us. Like, if you look at the India graph, we can see that in the month of April, from January to April, it has gone down, but then it has started picking it up. But if you see in the another country like South Africa, the graph is still going down and it hasn't been able to still pick up. So this is just one area which I just put it up from the report, just to see that how much it is affected, how much the pandemic or how much COVID-19 has affected the TB response. And there are also, as we all know, there are also many reports which has come up recently, the modeling study report, Stop TB, and the civil society report, of which GCTA was also part of, which says like very, very worrisome figure in the sense that we are at a setback of about 5 to 8 years. And then there will be another additional 1.6 million deaths. And the figures is like really, really big. And we really need to do more than what we were doing before, because the pandemic has really affected the TB care. Next slide. And now looking at the response, like what has been the response to the disease so far? As it is, as we all know, I mean, like it's not a very new disease. It's a very old disease, which the bacteria was discovered in about 1885 or 1888. But initially, the response to the disease has been like medicalized. But in the recent days, we can see that we are seeing, I mean, we haven't reached up to what we aim to do, but we are seeing a change in diagnosis and treatment regimes and all. And we are also in the process of scaling up for the rights-based treatment. And this is something where, I mean, many of us are working, and where GCT is also particularly focusing on it. And other than this, we have many global commitments, which we have seen in the past: the SDG, WHO, NTB strategy, the first where bold targets were being met on to solve the problem, to reach the missing millions, and to bring an end to tuberculosis. And recently, we have seen the global plan to end TB, where there is a paradigm shift of involving the communities, the 1990 target. So you can see that the changes in response is also happening, but it is not happening at the speed that it should be happening. I mean, there are so many things that still needs to be done. So now then, the next slide. Yeah. Now, this is just to give us an idea of where are we at the moment. So you can see, I need not tell out the figure, which the number in the circle is the target, and in the side is the number where we have reached now in terms of SDG and the NTB strategy, and in terms of UNHLM. So this is just an example that which I'm taking out from the report which was launched yesterday, just to give us an idea of where we are. So we can see that the figure, the evidence, the grassroots experience, the sharing from our friends at the ground, all shows that we are not really, something is missing, something really is not going in the right way, and more efforts needs to be given. So that's where we comes in the importance of monitoring. Next slide. Yeah. So now coming back to the topic of monitoring, as we all know, I think all of us are involved in public health program for a very long time, and we know that monitoring is a very important part of any public health intervention that happens. I mean, it is just to give us an idea of whether we are going in the right track or not, just to have we have a goal and objectives of a program. And monitoring is something, I mean, it's not a very scientific, it is a scientific concept, but it is something which we use in our daily life as well, and which we know, like in schools, colleges, everything, we know that there is a monitoring system which happen. But this session particularly is focusing on, now when it comes to monitoring, why are we talking about what is the need for the community monitoring? So next slide, Priyanka. The need for the community monitoring is because, as we all know, as we have seen in our program, as we have seen in the history, that community in any program or in any public health intervention, in any public health approach, if the community is not involved, then it doesn't have the desired impact. I mean, just to give an example of from the place where I come from in Northeast India, just look at I'll just give an example of overdose. Like overdose among the injecting drug user, which was taking the lives of so many people some 10 years back, 15 years back, because the environment was as such that if people die, or like if a drug user has an overdose, then it's illegal to buy the medicine. You have to procure it. There is a problem in procuring the medicine. It's at a high cost. It becomes a police case and all. But then with the involvement of the community, it is now listed under an essential medicine list, where it will be available in a public health setup. So this is the power of the community, and not just in the drug user. I mean, we have seen it in our HIV, where there has been a community involvement in the scaling up of the ART all over, where there has been like peer-led counseling, peer outreach work, peer training. So that's why in the case of monitoring also, we really need to bring in the community, because we can have monitoring done by professionals, or we can have monitoring done by other service providers, but the missing link, the community involvement, only will only be able to tell us where is the missing link, and where is the thing that which is missing, which can bring a change in the program. And if something is missing in the program, then only it can be taken up as an advocacy issue, and then it can be, we can have a program which will give us the positive results. So these are the power of community, and community-led monitoring will only enable the program to do better services and the optimal uptake of services among the people which the program is designed for. Because as I said in the beginning, also in TV response, also what we really need now is some kind of a targeted approach towards the marginalized population. I mean, this is what is missing now, and this is what needs to be done. And in order to have a targeted approach, in order to target the key populations or the inadequately served populations, and we have to bring in community at every level, planning, service delivery, monitoring, everything to have a positive impact of the program and to get the desired result. Yeah. The last slide, I would like to conclude with saying that community are the best to know the change that is required. I mean, we have seen some examples, like, when we are doing an HIV intervention program during the condom promotions, or a harm reduction program, where a simple thing like having a shower in a drop-in center can bring in the uptake of services to a greater number than, or changing the timing of a drop-in center for sex workers. So these are some of the things that there are some changes that maybe a professionals may not be able, will overlook at and will ignore it, but small changes. And if some things are not happening at the right way, in the right direction, at the service delivery or at the ground level, then that can be taken up forward as an advocacy, and that will enable in bringing other real change that is required. So I would like to end my presentation with the saying that community members, when they're empowered with the right information, knowledge, and science of TV, along with the skills, they are the best place to advocate for the people-centered rights-based TV response. Thank you. Yeah. Over to Blessy. Blessy, are you there? Okay. So I think Blessy is in a call at the moment. I would like to call upon the next speaker, Alain. Alain from, I hope I'm pronouncing your name correctly, Alain from ITPC. He is the community monitoring lead, and Alain will take us through the lesson learned from ITPC CTO model. Over to you, Alain. Thanks.
Thank you very much, Archana, and good afternoon again to everyone. Don't worry, you pronounced my name very well. And I would like to thank you, GCTA, for this opportunity you give me to come and speak on this platform about what ITPC has been doing so far in terms of community-led monitoring, especially focusing on community treatment observatory. So I'm going to share my screen so that everyone can follow when I'm speaking as well. Can you see my screen?
Yes, we can. Please go ahead.
Okay, thank you very much. Okay, so first I would like to share with you how and within ITPC we define community-led monitoring. So first of all, community-led monitoring is monitoring of service by communities where they are the end users, is a routine activity, is monitoring of indicators that are relevant to that community in order to improve services. And its community monitoring provides also evidence-informed platform for the too often missing voice. And if I have to add something into this definition, I would say community-led monitoring is an essential voice in creating the dynamic between what the state must deliver, what providers must give, and what community must contribute. So the community-led monitoring and CTO is based on the theory of action for ITPC, and it's based on what we call the 4 quadrants. One is education, evidence, advocacy, and engagement. Through education, we are looking for increasing demand for optimal and quality HIV prevention and treatment, related right and standard of cares. Through evidence, we increase evidence-informed advocacy as a result of a larger body of evidence that captures both granular and systematic HIV and health issues as relevant to communities. Advocacy is meant to improve health outcome as a result of an increased access to optimal and quality prevention and treatment. And engagement is meant to uh, increase government accountability and investment in community-led monitoring. So this is a theory of actions which base the action from ITPC. And because we have based our model on HIV, we develop our approach alongside the HIV cascades, as you see. So from the first 90 in terms of prevention, we look at what are the services available and what are the community left behind. Regarding care treatment, we look at how the enrollment in, and the ART services are done, and what are the treatment combination available. And also the last 90 for viral suppression, we look at the time for result to be provided to the communities. So the CTO is a mechanism that systematically and routinely collects and analyzes qualitative and quantitative data. I would like to stop a bit on qualitative and quantitative because sometimes we forget the qualitative aspect of data collection. And it's both qualitative and quantitative data which take us through the CTO and to make sure that we understand the why, the how, and the what's. The data is used for monitoring trends along the HIV care cascade and to inform targeted action that will improve the quality of HIV services. And here we are talking about HIV, but it could be also adapted to malaria and TB. And we are currently piloting a CTO approach with GCTA around TB and to see how we can make it work. CTO are a systematic and continuous monitoring process. Data is collected as a set of intervals. It could be monthly, it could be quarterly, it could be every 2 weeks, and enter into a centralized database. After being collected and checked for quality, the data from all sites is analyzed and the results are used to inform targeted advocacy. So it's important that we put the focus on the quality because usually when it comes, data come from community or civil society, there is also always this discussion, are they real data, are they true data? So this is why it's important that we put the focus on the quality check. The CTO can operate at district level, at provincial level, at national level, and regional and global level. And we can do a scale down CTO as well. So during the past 3 years, we have implemented a regional community treatment observatory in 11 countries in West Africa: Benin, Cote d'Ivoire, Gambia, Ghana, Guinea-Bissau, Liberia, Mali, Senegal, Sierra Leone, and Togo. And it was both for quantitative collected on a monthly basis and qualitative on a quarterly basis at health facility. Community data collectors were coming from PLHA networks and KP's organization. And in Southern Africa, it was implemented in 3 countries: Malawi, Zambia, and Zimbabwe. And it was used, the same approach was used. But for Southern Africa, we tried to improve the data collection process by moving from paper-based to digital. So we are both and trying to see how community data collectors were behaving with digital technology. So how the structure of the CTO looks like. The CTO is not a standalone. It's embedded within a host organization. For example, you cannot say it's a project. It's within the organization. And the host organization is the organization which hosts the community treatment observatory. For example, if we talk about GCTA, we will say we have GCTA is leading on the CTO, focusing on TB in India. So, but going back to the model, we have at the bottom on the ground, and this is where the work starts. We have the health facilities or the community-based facility, depending on the type of indicators you would like to collect. And within the health facility, we have the data collectors. They work with the health facility people to collect the data based on different indicators which have been designed. And these data are collected on the site. And this site, as I say, could be community-based facility or public health facilities. And then we have what we call the data supervisor or data checkpoint, is a data collector who is able to review the initial information provided by the data collectors and making sure that these are correct before passing this data to the CTO focal point. The CTO focal point is a person named by the host organization to coordinate the CTO work with the data collector on the ground and preparing the discussion with the organization, but also with the key stakeholders. But because we put a focus on the quality and the interaction and the data need to be validated, there is an interaction between the host organization and what we call the community consultative group first. The community consultative group is a platform of partnership where you have different stakeholders and also the beneficiary who review the data which has been presented to them to see if the data makes sense and what are the advocacy agenda. But before it goes to the community consultative group, there is an academic institute or an independent expert. So it's not an obligation to have an academic institute. It depends on the budget you have, because this is an investment. So if you are not able to afford an academic institute, or if an academic institute cannot do this work pro bono, you can also contract or work with someone with an expertise to do data analysis and review them. So this is another level of quality check again, and before presenting the data to the community consultative groups. So this is a basic structure of the CTO, and again, it can be adjusted and tailored to the different contexts. So how the data flow is operating. As I say, from the bottom, from the ground, from the health facility, from the community-based facility, data collectors collect the data. It could be paper-based or mobile, using mobile technology. And then it goes to the data verification through the data supervisor. And then this gets uploaded into the database, which is located within the host organization. Once all have been translated into actionable action, this is now you move to the advocacy activity. And this is quite important, because when you have all these data analyzed, you will see what could be the advocacy agenda you have to implement to improve change. Okay, so CTO collects and analyzes data on what we call the 5 A's. The 5 A's are related to availability. So availability is to make sure that the required services are available, they exist. If they exist, are they there on a real time? After you look at the accessibility, it's related to the distance people have to travel, the waiting time, the hours of operation, the referral process along the care cascades. The acceptability is related to the quality of care, the services, whether they are free of stigma and discrimination, and whether or not the human rights for patients are promoted and protected. The affordability is whether or the services will require out-of-pocket spending on behalf of the clients, if the service delivery model is efficient, and what is the sustainability response, what is happening after this pilot. And the appropriateness is whether services are tailored to specific needs of key and vulnerable population, and if you have age and gender considered in services package. So these are basic questions, and you can add additional question as long as you fit within the 5 A's. So this is some results from the Regional Community Treatment Observatory in West Africa. So you see that we have been able to look the frequency of ART stock out, the lab supply as well, the average length regarding the ART stock out, for how long the stock out were not, the ART were not available. We also have the viral load test performance and also the viral load suppression. So these are the key results, some of the key results I can share with you. When it comes to viral load test results in terms of waiting time, you will see in this graph that sadly only 1 on 4 viral load test results were returned to the patient within 2 weeks. So if you see that you have the average was within 2 weeks, it was 25%, more than 3 months was 19%, and between 15 days and 3 months, it was 55%. So just to say that the CTO work helped the community to engage in reducing the waiting time for the viral test results. So actually, when you see the trend in some countries, a specific country like Sierra Leone or Cote d'Ivoire, now they have moved from 2 weeks to 5 to 10 days. So there are improvements on the ground. So in terms of advocacy, in a country like Mali, the OCTO, who was the network of PHIV, used the CTO data to improve quality of care in health facilities by improving data quality and individual patient monitoring. So investing in community will allow you to achieve results. So you are able to see that, for example, in Sierra Leone, through the project networks of people living with HIV/AIDS, we're able to mobilize additional funds from the partners. We say that the money we got from the Global Fund was a kind of catalytic, because we have to implement this into 11 countries. And today, because of the result and the role of a community actors and activists who were at the center of the response, show that investing in our community will achieve results. For the sustainability, this has been included in the Global Fund proposal under the NFM3. PEPFAR also funded some of the activity, and we have some, we support resource mobilization with French 5 initiative in other countries. So it means that it's important that you show result. The quality of the work will be definitely critical in the sustainability of this CTO. So what are the lessons learned and challenge and success factors? First, strong leadership is critical. The more successful observatory has strong leadership within the national network and high-level political buy-in. It means that there was a strong commitment from the network itself to own this process, and also at the CCG level, where you have a strong leadership in the CCG, the chair of the CCG was able to open door and to do a lot of communication around the work, sharing with the other stakeholders and talk about sustainability. Second point is the model must be embedded in the national response. As I say again, it's not a standalone, and it needs to be part of an organization, but mainly also working with the government, because we need to work with the government. At the end of the day, we are here to improve health services for communities. So it's not about pointing the finger at the government. It's about showing critical things, but also making some recommendation. How do we see things to be improved? Moving from ad hoc alert to systematic monitoring is key. It's not about ringing the bell. You need to say, yeah, this is an issue, but here, this is what we are coming to. For example, if I take the issue of viral loads tests, we discovered that network of people living with HIV needed to do more campaign among the constituency to explain to them the importance of viral loads. It was not only because the results were not given on time or services were not available, but people needed to understand what was the importance of viral load tests. And different observatories function at different levels. So you can have an observatory at the city level, you can have at district level, you can have at national level. The model remains the same. It can be flexible and it can be adjusted. And data-driven advocacy works. So the result and analysis from Côte d'Ivoire, from Sierra Leone Observatory has been successfully used for removal of user fees in the country, and also express interest in investment. So, and Ambassador Burks, 2 years ago, when she saw the result from the different countries, especially in Côte d'Ivoire, she said to her colleague, why these organizations which have less money than us are able to show what we are not able to see. So this is important, and this is what you need to have in mind when setting up a CTO. Thank you very much for your patience, and I'm looking forward to more discussion. Over to you, Blessy and Archana.
Thank you so much, Alan. That was really, really good. And I think this is one gap in the TB world. I think we haven't sort of done this sort of systematic monitoring and reporting. And somehow in the TB world, people get scared of the word monitoring. They think it's some sort of a policing. So I was very excited to listen to you. Of course, this is not the first time I've heard about this. And just to say that along with ITPC and Alan's support, GCTA is attempting a very small sort of CTO for TB study. We are on. We have already started it, and but it's very small compared to what has been done in the HIV. But this is just to, help us see if this is something feasible. So thank you very much for your guidance on that. And I think it's important for us to remember strong leadership working with the government. And I really liked what you said about moving away from ad hoc to systematic reporting. I think that is something sometimes as activists we get carried away with this sudden, ad hoc sort of raising of issues. And also advocacy that is data driven, not just feelings and passion, but actually we have the data. And I think we've learned that from the COVID response and TB. So thank you very much for those very, very helpful and insightful points that you brought. Alan, thank you. And next we have three very, very important and significant colleagues of GCTA who will be speaking. I would like to call on them and introduce them first, and then they can go one after the other. First is Prashant. Prashant is a member of the National Coalition, which is the Touched by TB. And he spoke very powerfully recently when we launched the India data sheet of the COVID survey report. And he's personally experienced the disastrous effects of TB on his family. And he's from Sikkim. And we'll request him first to share with us. And you have about between 6 to 8 minutes, Prashant. Please go ahead.
Hi, Bessie. Can you hear me?
Yes.
Yes,
Yeah. So, shall I start
Yeah,
please do.
straight straight away?
Yes,
Okay.
please do.
So, thank you so much. Warm greetings to everyone. I'm a Prashant. I'm a community member and a TV survivor. As you said, I'm from Sikkim. So, in Sikkim, I represent a forum called Sikkim Drug User Forum. So, today I am here to talk particularly about the TV response, especially amongst the PUD. uh, or PWIDs in India. Uh, I think there is a slide, there's a presentation. I think you have
Yeah, it's
put
on
up.
the
Okay.
screen.
So, okay, yeah, thank you. So, the country I come from is on the lead, having highest TB burden. But then the good thing is like country or the government is very committed to end TB by 2025. And even further, my state where I represent is even committed to eliminate TB by 2022. But then coming from the ground, I not really doubt the intention and the mission behind the ending or eliminating TB by 2025, 2022, or 2030. But then what is going on is like completely different. People are still dying because they don't have access to services. And talking about particularly, if you see the TV program, then it is largely between the general community and the HIV community. And I think that's where we are the missing link. And if you see the global landscape on the disease of the marginalized community, such as HIV, HCV, hepatitis B, amongst the PWID or PUDs, are amongst the biggest contributor or infected. According to the Lancet on the global health paper, tells us that some of the highest infection are among the PUDs. You can see it as the percentage wise, 17.8 percentage HIV and HCV is 52.3%. And even the history of incarceration is really, really high among the people who use drugs. However, when it comes to TB, there is no evidence, or I would say there is nothing in relation between TB and drug use. And therefore, there are no services on TB for drug users unless drug users are HIV positive. Uh, yeah, can you go to the next slide? Uh, yeah, thank you. So, as a drug user and as a TB survivor, and who has lost a father, an uncle, and a family member because of TB, I would like to say that the PUD, especially the community that I represent, face several barriers in accessing health services. The best example I can give you is like HIV itself, where drug users have the lowest service uptake in Asia and even India. And the reasons are, as you can see in the slides, there is such a low service coverage for drug users. And there is no mechanism or there is no as such uh, a program or a guidelines has been so far developed to, to link people who use drug to the TV services. There is a huge gap in the TV service delivery. There is a low capacity, especially among community-based organizations to deliver services at scale. And one of the biggest challenges is the legal and policy barriers. And one of the reason we all know is that we are being criminalized, we are being moral policing, we are being stigmatized, we are being discriminated because we chose to use drugs, and then we are often ignored, and then we are not seen as one of the very important uh, people in our community or in our society. And even further, there is a huge low in financing when it comes to the TV responses among the people who use drugs. Can we move to the next slide? Uh, all of us know those who are here attending this conference how TV transmit. But then, there is two very important reasons why TV response among the drug users are important. Not only important, it is indispensable that we have to understand. People use or inject drugs in a group or in a poor conditions, and also drug users shares paraphernalia among their peers and among their friends, and that makes them very vulnerable, and that makes them very risks uh, to get TB infections. So another reason is drug users are often found in closed settings such as prison, drug treatment, detention center, as such. So it becomes very, very difficult if we don't prioritize, particularly in those settings. Uh, can we go to the next slide? Uh, uh, so we have studies from India which found that the drug users started using drug as early as 13 or 14. I myself started using drugs when I was 14, and when they when the drug user come in a contact in the health services is only when they are late 20s or early 30s. So I'm still living with hepatitis C, but then I'm cured from TB. But then till date, I have not got my hepatitis C treatment. I only came to know uh, 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 maybe in 2015 that I was a hepatitis C positive. So this is the ground reality that how services delivery system actually exist. During this time, because there is no early diagnosis, prevention, or treatment, they only come to services when PUDs are already HIV, HCV, TB positive. This is why
Hello, we can't hear Prashant.
Prasad, yeah, I think we lost him. Yeah. I'll just check up with him.
Should we
Yeah, I
move to, have you managed to
no,
get
I'm
Prashant?
not getting.
Okay.
Huh.
So let's move to Kusum now. Kusum is
yeah.
actually the
I think
Can you
I
president.
think
can you
I
continue?
think
Yeah,
Prasad is
yeah.
back.
Oh, okay,
Yeah,
sorry.
yeah.
Please continue, Prashant.
Yeah.
But then I just like to request you here, if my connection get little, if I'm lost or something, then please continue with other speakers. So can you hear me now?
Yes, yes, we can.
Yes, we
Okay.
can. Please go ahead.
So can we move to the next slide? Uh, okay. Hmm. So yeah, so as I've already said, that the TV response among the PUD is indispensable. It is very, very important. So that the other factors such as better housing, nutrition, access to harm reduction services, and HIV treatment is prioritized among the people who use drugs. Otherwise, TB will still continue to kill more drug users without knowing, they are dying from TB. The services which is available does not really look into what kind of challenges the people who use drugs face. It's very difficult system that which we have. Just to give you an example, just during this COVID, government they itself come with some kind of financial package for a TV community in my state, providing them some little cash so that they can at least sustain their lives. But then when it comes to people who use drugs, some of the government leaders have straightforwardly said that if the person is a drug user, should not be given that that financial assistance to people who use drugs, and that sort of things which makes people who use drugs more reluctant to access those services, because the stigma and the moral policing, and then such kind of uh, 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 picturization among the drug user is really worse. I believe it's everywhere. So yeah, and that's the reason why that the community plays a very important role. During the COVID also, we came forward and we tried to provide all in our capacity to provide all kind of assistance to uh, TV people, no matter who they are. We didn't just thought of our community or people who use drugs. We care for everyone. We try to reach out to maximum as we could through providing essential commodities, protective gears, some financial assistance, whatsoever in our capacity. But then when it comes to the program settings, then it's more challenging to enter there. In India, we have uh, uh, in a government system, we're supposed to have a state level TV forum or a national level TV forum. But then when there is, uh, I mean to say, like there is a very little space for the people who use drugs, because we are seen very differently than other communities. So that's one of the very reason that why the people who use drugs needs to give all kind of attention. So uh, there are some steps to control TB infection and TB treatment amongst the PUD. Most important for me as the community member or a TB survivor to involve in my community meaningfully, especially in treatment literacy, mass awareness, and linkage to a TB testing and treatment. Uh, Whenever I was talking to many of the people from my community who is accessing TB treatment from last more than 2 years, and I've just asked them a very simple question such as, what kind of medicine you are having? Then they have no idea. They don't know what are the medicine they are putting in their bodies. And even I have asked them about the testing, and then even I have asked them about how the TB one person can infect another person, and the knowledge or the literacy about the TB among the community is so poor. And when it comes to family, it has become like a corona, you know. Now you have been quarantined because you get the infection, and you have been kept in another room, not only in another room, but then if you see when it comes to TB, then you are provided everything in another room. You are given utensils, you are given stove, and then you are kept isolated in that particular room for a very long time. That makes more reluctant for them to continue with the services. The state I come from, where it is a very high rate of suicide among the TB population, and mostly they are from the users community. And I think the thing which we are doing when we are talking about the community monitoring system, this is, I think, the best way to understand and to provide services to uh, the community who is especially affected more. Lastly, I would like to, the next slide. So those are the few examples that how things are in uh, are places like, if you look into the prison, or if you look into the closed settings, or even the health settings also, it is bizarre. It is bizarre, and no one knows about, how to, care. Now people know about corona, but then people really don't know about TB, and TB being one of the oldest disease, but still people don't know about TB. And then often that has led to more and more infections, more and more TB burden, and more death. So yeah, the next slide. I think I have addressed this also. Then can we go to the next slide? I think I'm almost finished. So the lastly, I only want to say is, like, we are dying basically here, and people are dying because we basically don't get access to the services which the government commits to do it. But then just because I use drugs, or I chose to use drugs, I've been excluded from the TV response. So to everyone, thank you, support, don't punish. Thank you so much.
Thank you so much, Prashant. That was really quite powerful. And I think in the TB world, we do need to learn how to work with communities who you inject drugs. That's why we also have our next speaker, because we, as the Global Coalition of TB Activists, really believe that in TB, we can't just leave those who are anyway left behind, those who are marginalized. And our effort is always to bring them to the center. So, which is why we are so happy to work with you, Prashant, and we will continue to work. We will not rest till you get the full support, the community gets the full support. And I hope that the things will change and we don't have to keep asking people for support, that it will be a normal thing. Yeah, thank you very much for sharing this. Next, I'm really delighted to invite Kusum, a dear colleague, and she's also the president of All India Network of Sex Workers. And over the last year and a half, couple of years, I've had conversations with Kusum, kind of asking her why she's not doing anything about TB. But she has always assured me that TB is very much there in the agenda. But, again, like what Prashant was saying, I don't think we proactively engage with communities like the sex workers or other networks that are anyway marginalized and are inadequately served. Kusum ji, बहुत बहुत धन्यवाद आपको कि आप हमारे साथ आके थोड़ा
थैंक यू मैम।
तो Kusum will speak in Hindi and Priyanka will translate that. We wanted to be inclusive, because language should not be a barrier. So even though we didn't have any formal translation facilities for this, we thought we should still go ahead and try and do whatever we can as GCTA to be inclusive. So आप हिंदी में बात करेंगे और प्रियंका थोड़ा ट्रांसलेट कर लेंगे। ये बहुत जरूरी है क्योंकि भाषा की वजह से लोगों को अलग नहीं करना चाहिए, तो इसलिए हमें लगा कि आपको यहाँ पर बात करना, ये यूनियन कॉन्फ्रेंस में बात करना काफी इम्पोर्टेंट है। So welcome, and now I invite Kusum to please share with us her thoughts on why it is important for community to monitor whatever the implementation that has been going on, or the targets and the commitments that have been made. Thank you, Kusum.
थैंक यू ब्लेसी मैम। मेरी आवाज आ रही है?
आ रही है, प्लीज गो अहेड।
हाँ, ओके। तो नमस्कार फिर से सभी को। मेरा नाम कुसुम है, मैं ऑल इंडिया नेटवर्क ऑफ सेक्स वर्कर की प्रेसिडेंट हूँ। और आज मैं थैंक यू करना चाहती हूँ कि मुझे इस प्लेटफॉर्म पे बात करने का मौका मिल रहा है। कम्युनिटी का जो व्यू है, कम्युनिटी का जो बहुत दिन से चलता है कि हमें हर जगह हमारा पार्टिसिपेशन होना चाहिए, चाहे वो हेल्थ डिपार्टमेंट हो, चाहे वो कोई भी सरकारी सुविधा या कुछ भी हो, तो उसके लिए उनका जो लगातार रहता है। तो आज हमें लग रहा है कि हम कहीं ना कहीं इन सभी चीजों से धीरे धीरे जुड़ते जा रहे हैं। ओवर
Hello,
प्रियंका।
my name is Kusum and I am the president of All India Network of Sex Workers, and I am really happy to be here today. And it has been a long-standing struggle that communities, and especially the sex worker communities, are not included in all platforms, but I am extremely happy that today I have the chance to be here and say what I need to say. And it really feels that the tide of change is coming in and we are feeling more and more connected.
प्रियंका,
कुसुम जी, मैं आपके लिए ये स्लाइड और सभी लोगों
हाँ
के लिए
बिल्कुल, मैं स्लाइड देख रही हूँ प्रियंका जी। हाँ हाँ,
मैं आपके लिए पढ़ देती हूँ. I'm just going to read out the slide for the benefit of Kusum and all the other participants. The first point she'd like to talk about is transparency. Community-based health monitoring provides transparency in mechanism. Program aims to reach last member of community to provide support, and community involvement in this process helps to provide support with transparent mechanism. कुसुम जी,
हाँ
ट्रांसपेरेंसी
तो
के बारे में
अगर
आप
हम
बात कर रहे थे.
खुद, हाँ ट्रांसपेरेंसी से, हाँ ट्रांसपेरेंसी के बारे में मैं बात करना चाहूंगी। तो ट्रांसपेरेंसी उस तरीके की कि जैसे हम जिस हेल्थ डिपार्टमेंट में जा रहे हैं, हमें नहीं पता है कि वहाँ पे कुछ चीजें कम्युनिटी के लिए आई हैं, वो हैं या नहीं है। अगर कम्युनिटी खुद मॉनिटरिंग सिस्टम में रहेगी तो वो देख पाएगी, समझा पाएगी। मतलब कि कम्युनिटी मॉनिटरिंग सिस्टम का मतलब है आप हेल्थ डिपार्टमेंट के और अपनी कम्युनिटी के बीच आप ब्रिज का काम कर रहे हैं, बिल्कुल ट्रांसपेरेंट ब्रिज का काम। आप ट्रांसलेट करिए प्रियंका।
Being a part of a community monitoring system, as a community member, it means that you are just not a part of the system, but actually a bridge between the government systems and the community at large.
और उस तरीके से आप उन लोगों को भी ट्रांसपेरेंसी दे रहे हैं जो हेल्थ डिपार्टमेंट या किसी भी सरकारी सुविधा में बैठे हैं, और आप अपनी कम्युनिटी को ट्रांसपेरेंसी दे रहे हैं कि वो उस अधिकार और उस मतलब कि उस अधिकार के साथ वहां पे जा सके। अपने लिए जो उनकी सरकार की तरफ से जो सुविधा है हेल्थ को लेके, वो किसी भी डिपार्टमेंट को लेके, तो वो आसानी से ले सके। उनके साथ किसी तरीके का कोई भी भेदभाव या कोई चीजें ऐसी ना हो कि उनको पता ही ना चले। तो उसको ना पता लगने वाली चीज को हटाने के लिए हमें मॉनिटरिंग सिस्टम में ट्रांसपेरेंसी का रहना बहुत जरूरी है।
Community monitoring is very, very
और
important to make sure that the communities and the government systems are not blindsided at any point of time. The community members are aware of what all services they are eligible for, and they can march up with the rights and ask for the services that they should be provided for. And at the same time, we are able to tell the government systems as to what the ground level realities are. कुसुम जी, मैं आपके लिए
प्रियंका,
अगला
हम नेक्स्ट
point,
पॉइंट पे, हाँ
हाँ,
हाँ
improve
हाँ
service
बिल्कुल, हाँ
delivery mechanism.
मैकेनिज्म। हाँ, जब हम अपना हमारा एक मॉनिटरिंग सिस्टम होगा, कम्युनिटी का एनवायरनमेंट होगा, तो हम देखेंगे कि जो सर्विसेज की डिलीवरी है वो किस तरीके से हो रही है। जिस तरीके से हमारे लिए वो सर्विस डिलीवरी कागजों पे बनी हुई है, उस तरीके से वो हकीकत में लोगों तक पहुंच पा रही है या नहीं पहुंच पा रही है। उस सर्विस डिलीवरी में वो क्वालिटी है या नहीं है जो हमें एक बोर्ड पे लिखी हुई मिल रही है, या हम उसको एक्सेस करने में उस चीज को देख पा रहे हैं या नहीं है। तो अगर कम्युनिटी मॉनिटरिंग सिस्टम रहेगा तो हम सर्विस डिलीवरी का मैकेनिज्म को अच्छे से यूज कर पाएंगे। उसमें
Improving service delivery mechanism means that we are able to translate what is written on the paper or on a board to actual actions. When there is a strong community monitoring system in place, we will make sure that there is accountability and there is no gap between the written word and the implementation of actually how the service delivery mechanism has to be implemented, which means better resource utilization, and better benefits for the community at large.
और मैं अपने तीसरे पॉइंट पे आ जाऊं।
जी, लीडरशिप डेवलपमेंट। जी कुसुम, मैं आपके लिए तीसरा
हाँ,
पॉइंट
लीडरशिप डेवलपमेंट की मैं बता। हाँ,
लीडरशिप
प्रियंका मैं
डेवलपमेंट
आपको सुन नहीं पा रही हूँ।
Can anyone else please confirm if they can hear me?
Yeah, we can
Yes,
hear
yes,
you.
we
Let
can
her
hear
go
you.
to the third
या
point. कुसुम, आप तीसरी पॉइंट लीडरशिप डेवलपमेंट के बारे में बात कीजिए।
हाँ 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 हाँ, मैं बात करती हूँ। अगर देखिए हम मॉनिटरी सिस्टम में आते हैं और हमें एक जगह मिलती है, जैसे कि आज मैं यहाँ बात कर रही हूँ तो मेरे अंदर एक लीडरशिप है कि भाई हाँ, मैं इतनी सारी कम्युनिटी की लोगों की जो भावना है, जो उनके विचार है, वो मैं जानती हूँ, मेरी कम्युनिटी क्या चाहती है और मैं लेके आज यहाँ बैठी हूँ। तो इसी तरीके का हम किसी डिपार्टमेंट में जाके बात करेंगे, वहां बैठेंगे तो हमारे अंदर ऑलरेडी एक लीडरशिप आती है ना, हम डिसीजन मेकर होते हैं वहां पे अपनी कम्युनिटी को लेके। तो जैसे कि आज मैं यहाँ हूँ और जब हम इस तरीके से मॉनिटरिंग सिस्टम में आएंगे अपने स्टेट में, अलग अलग स्टेट में, अलग अलग डिस्ट्रिक्ट में, जो वहाँ के लोग हैं, वहाँ के जो ग्राउंड पे काम करने वाली हमारी बहनें हैं, जो हमारे कम्युनिटी के लोग हैं, तो इस तरीके से अगर मॉनिटरिंग सिस्टम में आएंगे तो उनके अंदर एक लीडरशिप पावर अपने आप आ जाती है। तो मॉनिटरिंग सिस्टम में इन्वॉल्वमेंट का मतलब अपने आप में एक लीडरशिप आना। ओवर टू प्रियंका।
When we are a part of a community monitoring system, we become leaders in our own accord. We are empowered and engaged to be able to walk up to government officials and ask for what is rightfully ours. And we are also able to translate the words and the action that other people, like for my example, my sisters who are other sex workers who are working on the field are taking, and we are able to translate that to the government officials and talk about the work that we are doing. So for the community, when we are a part of a community monitoring system, we have the chance to become leaders of our own destiny.
Thank you, Priyanka. Next point, Priyanka.
Confidence building. Programs should have aim to build confidence of community. Program implementation and monitoring provides them to build their confidence and learn more things.
मैं मॉनिटरिंग सिस्टम, मैं किसी भी डिपार्टमेंट में बैठी, वहाँ मेरे लोग वहाँ पहले जाते थे, उनके साथ उस तरीके से नहीं भी उनका बिहेवियर था, कुछ नहीं था, तो लोग वहाँ जाने से डरते थे। अगर मैं वहाँ बैठी हूँ अपनी कम्युनिटी के लिए या मेरा कम्युनिटी का कोई वहाँ पे बैठा है, तो मेरे अंदर कॉन्फिडेंस आता है, मेरे अंदर एक विश्वास आता है कि मैं वहाँ जाऊंगी तो मुझे अच्छे से अच्छा ट्रीटमेंट या मेरी बातें अच्छे से सुनी जाएंगी या मैं जो वहां जाके पाना चाहती हूँ वो मुझे अच्छे से मिल पाएगा। वो एक कॉन्फिडेंस आता है जब हमारी कम्युनिटी उस डिपार्टमेंट में होती है। तो अपने आप में अगर कम्युनिटी मॉनिटरिंग सिस्टम होता है तो कम्युनिटी में अपने आप एक अलग ही कॉन्फिडेंस आता है कि हाँ, मैं अपनी 4 बहनों को वहां लेके जाऊंगी तो मैं इस कॉन्फिडेंस के साथ लेके जा रही हूँ कि वहां अपना आदमी, हमारे साथ वहां कोई भेदभाव होने वाला नहीं है, हमारे साथ वहां पे कुछ ऐसी चीजें नहीं पूछी जाएंगी जिससे मेरे को कोई आघात पहुंचेगा या मेरे काम पे लेके मेरे साथ कोई स्टिग्मा या डिस्क्रिमिनेशन होने वाला है। तो उस तरीके का अगर हम चीजें रखेंगे तो शायद अपने आप में कॉन्फिडेंस आता है, अपना काम करने में कॉन्फिडेंस आता है, सर्विस लेने में कॉन्फिडेंस आता है। तो ये सब सारी चीजें इस कम्युनिटी मॉनिटरिंग सिस्टम से जुड़ी हुई हैं। ओवर प्रियंका।
When I talk from my personal experience, it has happened that we have walked up to the system and to a program or a government official, and we have been stigmatized and discriminated against, and we have been asked questions regarding our work, which can be really hampering to one's ego. But when we have strict community monitoring systems that are enmeshed within the government system, the other people joined with the community have a confidence that there is someone that represents my way, my point of view there, and I can walk up and ask for service delivery, and I can ask for things that are rightfully mine. That is the confidence that a community monitoring system that's enmeshed within the larger government system provides to a community member.
नेक्स्ट पॉइंट पे आए प्रियंका.
Inclusive system. We learned from HIV program to work together with government agencies and stakeholders. So community involvement at monitoring level makes the system more inclusive and participatory.
देखिए, जिस तरीके से हम इतने सालों से HIV साथ जुड़े हुए हैं, मैं नहीं जानती थी HIV क्या है. हम सेक्स वर्क में हैं, कोई हमें पूछने नहीं आ रहा है. HIV प्रोग्राम आया, हम अपने टेस्ट कराने लगे, हम अपने स्वास्थ्य की बात करने लगे. HIV के बाद हमें टीवी प्रोग्राम से जुड़ने का मौका मिला. उसके अलावा हमें इतने सारी चीजों से जुड़ा कि मैं अलग अलग चीजों से जुड़ पर आई. मैं अपनी और चीजों के अपने साथ हो रही हिंसाओं के बारे में बात करने लगी. मैं अपने बच्चों के अधिकारों के बारे में बात करने लगी. मैं अपने बच्चों की शिक्षा के बारे में बात करने लगी. मैं अपने एज ए सेक्स वर्क, एज ए वुमन के अधिकारों की बात करने लगी. तो इतनी सारी चीजें हमें जब जुड़ते हैं तो ये एक्सक्लूजन हमें मिलता है करने के लिए. तो अगर हम लोगों को, कम्युनिटी को इस तरीके से जोड़ेंगे, लोग एक दूसरे से जुड़ पाते हैं आसानी से, और लोगों के अंदर अपने आप में एक जज्बा आता है कि हाँ, मुझे जुड़ना चाहिए. यहाँ मेरी इस प्रॉब्लम का हल तो मिलेगा ही मिलेगा. मुझे दवाइयाँ मिल रही हैं, मुझे सब कुछ मिल रहा है, और मेरी और भी जो सारी चीजें हैं उनका भी शायद समाधान इस जगह आने से हमें मिल पाएगा. तो इसलिए इंक्लूसिव चीजें यहाँ से हमें. प्रियंका.
When we were working as sex workers and we continue to work as sex workers, and we then came to know about the HIV program, we started learning about the services that can be provided to us, and we walked up to the government stakeholders and were able to ask for the services. Then we came to know about the TB program and were able to ask for the services that are due to us. This led to a chain reaction, and I was able to talk about other things as well. I could talk about my children, the rights of my children, the educational rights of my children. So when we create an inclusive system, it starts off a chain reaction where the entire community is able to reach a higher attainable standard of life and care. Over to you, Kusum. Next point, quality assessment. Community can assure the quality of services and make its assessment at their level to provide best of their fellow community members.
तो कम्युनिटी जब जुड़ती है किसी भी सर्विसेज से, तो वो खुद इंश्योर कर पाती है कि वो सर्विसेज मुझे उस क्वालिटी के मिल पा रही है या नहीं मिल पा रही. हम देखते हैं ना, कितने सालों से हम HIV प्रोग्राम से जुड़े हुए हैं. मुझे पता था कि टेस्टिंग इस तरीके से हो रही है. मुझे 10 बजे जाना है, लाइन लगानी है. फिर मुझे लगा कि मैं 10 बजे उठ के जा रही हूँ, मेरा काम सफर कर रहा है. तो अगर मैंने फिर हमने वहाँ पे बात करना शुरू किया. ICTC सेंटर में एक एग्जाम्पल दे रही हूँ कि जो मेरी बहनें हैं वो रात को बहुत देर तक सेक्स वर्क करती हैं, सुबह वो लेट तक सोती हैं, तो वो सुबह 10 बजे टेस्टिंग कराने नहीं आ सकती. वो आएंगी तो दोपहर के बाद टेस्टिंग कराने आएंगे, और आपको कम्युनिटी के लिए उतना करना पड़ेगा. तो इतना लड़के हमने अपने ICTC सेंटर में पाया. फिर उनके जो काउंसलिंग का तरीका था वो गलत था. तो जब हम उस सिस्टम में आए तो हमने उनको काउंसलिंग के तरीके को, बात करने का क्या तरीका उनको बताया कि आप उसके काम को लेके उससे बात नहीं करेंगे. आप उससे ये नहीं पूछेंगे कि आपको ये काम मिला, आपको यही काम क्यों करने को मिला, आप और कोई काम क्यों नहीं करती, आपके घर में बच्चे नहीं है, आपके घर में कोई मर्द नहीं है कमाने वाला. वो HIV काउंसलिंग का पार्ट नहीं है. इस तरीके से आप पार्ट नहीं कर सकते. हमने उसकी क्वालिटी को जज किया कि भाई ये क्वालिटी नहीं है काउंसलिंग की. काउंसलिंग की क्वालिटी ये होनी चाहिए कि आपके साथ इन 4 कारणों में से कोई एक कारण हुआ है तो आप टेस्ट करा लीजिए अपना, और अगर आप NGO के थ्रू आ रहे हैं तो आपको उस तरह के क्वेश्चन पूछने की भी जरूरत नहीं है, क्योंकि वो खुद इतना काउंसिल होके आ रही है हमारे जरिए. तो हमने एक तो काउंसलिंग की क्वालिटी को बदला. तो इस तरीके से अगर हम उस सिस्टम में बैठे तो हम उसको बदल पाए ना. तो वही चाहते हैं कि जब हम सिस्टम में बैठेंगे तो हम उसकी क्वालिटी को इंश्योर कर पाएंगे कि जो वो दवाइयां आ रही है या वो जो ट्रीटमेंट हमें मिल रहा है वो उस क्वालिटी का है या नहीं है जो सरकार पहुंचा रही है, और बीच में जो डिपार्टमेंट है वो क्वालिटी को हमें दे पा रहे नहीं दे पा रहे। तो अगर हम सिस्टम में बैठते हैं तो हम इंश्योर खुद कर पाते हैं, अपनी कम्युनिटी को इंश्योर करा पाते हैं कि हाँ हमारी जो सर्विस क्वालिटी है वो अच्छी है, वो बेहतर है। जो डॉक्टर हमसे बात कर रहे हैं उनका तरीका अच्छा है, जो हमें से मतलब कि सेक्स वर्कर का जो डॉक्टर तक पहुंचते पहुंचते वो कितने लोगों से गुजर पाती है, वार्ड बॉय है, गेट कीपर है, नर्सिस हैं, तो उनकी जो वो सबका जो रवैया वो देखती है तो खुद परेशान हो जाती है कि मैं दोबारा वहां जाना ही नहीं चाहती, और उनको तो पता लग गया मैं सेक्स वर्कर हूं तो मुझे इस तरीके से ट्रीट कर रहे हैं, ये है वो है। तो हम उसमें सब चीजों की क्वालिटी को देख सकते हैं कि उनके बात करने का तरीका क्या है, दवाई दे रहे हैं तो वो किस क्वालिटी की दवाई है, सरकार ने जो हमारे लिए भेजी है, जो सुविधाएं हमारे लिए दी गई है वो उस क्वालिटी की है या नहीं है। तो हम इस सिस्टम से जुड़ के क्वालिटी को इंश्योर कर पाते हैं और कम्युनिटी को क्वालिटी की जो चीजें हैं वो उनको दिलवा पाते हैं। ओवर टू प्रियंका।
When initially we were fighting for the rights of our community members and other members who are working with the sex workers community, it used to be really, really difficult because one, the slots that were given for them for testing were at 10 a.m. in the morning, and it was not possible for them to be able to be engaging in sex work till late at night and then in the morning going and getting themselves tested at 10 a.m. So we stepped in and we checked and we said that the 10 a.m. testing does not work, and we fought for it and changed the testing times. The second thing was the counseling. The HIV counseling standards were not of quality because many counselors would ask people about why they are working in the field that they are working. Do they not have a male provider who can earn? Do they not have children? Why do they subject their children to something like this? Which is not completely acceptable, and hence we fought for that. If you are an HIV counselor, you need to counsel her about the safe sex practices and tell her why she needs to get tested. And that is what it is. The other thing was we were able to check for the quality of the drugs and the medications that we were being provided. So that is helpful. When you engage communities in a community monitoring system and bring them in, that is what happens. We are able to bring quality assessment and change things. The next point, कुसुम मैं आपके लिए आखिरी point पढ़ दे रही हूँ. Behavioral change and
बिहेवियर
communication.
चेंज, हाँ, ये एक बहुत बड़ा और बहुत अच्छा पॉइंट है सबके लिए, क्योंकि बिहेवियर चेंज सिर्फ कम्युनिटी को भी नहीं करना है, बिहेवियर चेंज जो डिपार्टमेंट के लोग बैठे हैं उनको भी करना है। अगर हम कम्युनिटी मॉनिटरिंग सिस्टम में होते हैं तो जैसे मैंने भी आपको एग्जांपल दिया कि हमने ऐसे काउंसलर को बताया कि ये आपका बात करने का तरीका अच्छा नहीं है, आपको उसको चेंज करना होगा, किस तरीके से सेक्स वर्कर से आप क्वेश्चन पूछेंगे वो आपको चेंज करना होगा। तो हम अपना तो बिहेवियर चेंज कर ही रहे हैं कि अगर मैं जा रही हूँ तो मुझे इस तरीके के क्वेश्चन सुनने को मिल सकते हैं, तो मुझे हाइपर नहीं होना है। मैं अपनी कम्युनिटी को समझाऊंगी कि हम अभी डिपार्टमेंट जा रहे हैं, डिपार्टमेंट के लोग हमें समझे नहीं है, अभी वो उनसे हमारी पहली मुलाकात है ना, वो आम लोगों को ट्रीट करते हैं, उन आम लोगों में हम नहीं है, हम एज ए इस ऐसे काम से जुड़े हुए हैं जो हमें लोग अलग अलग नजरों से देखते हैं। तो क्या पता हमें वहां जाके कुछ ऐसे क्वेश्चंस या ऐसी बातें सुनने को मिले, तो हमें अपने लोगों का भी बिहेवियर चेंज करना है, और जो सामने बैठा है बंदा जो हमसे बात कर रहा है चाहे वो किसी भी डिपार्टमेंट में हो, उसका भी बिहेवियर चेंज करना है कि जी हमारी कम्युनिटी अपने काम के साथ आपके साथ आ रही है कि हाँ मैं एक सेक्स वर्कर हूँ तो आपको मुझसे किस तरीके से बात करनी चाहिए, आपका बात करने का तरीका क्या होना चाहिए, है ना, जिससे मैं परेशान ना हूँ, मैं वहां जाऊं ही ना सर्विस लेने। तो इस तरीके की जो बिहेवियर चेंज वाला कम्युनिकेशन है वो दोनों तरफ का बिहेवियर चेंज करने में मदद करता है, और उससे एक ट्रांसपेरेंसी आती है, कम्युनिटी आपको अच्छे से अपने बारे में बता पाएगी, और आप भी अच्छे से कम्युनिटी का जो भी सर्विस देना है, जो भी ट्रीटमेंट देना है, आप अच्छे से दे पाएंगे। तो ये बिहेवियर चेंज जो कम्युनिकेशन है वो दोनों तरफ से हमारी मदद करेगा। शुक्रिया प्रियंका।
Thank you, Kusum. I am building upon the last example that I gave, that when an when a counselor was not able to correctly help or correctly counsel the sex worker community members because they had certain prejudices, we were able to come in and say that no, you need to change your behavior because this is not the right way that you talk to a community member. But in the same way, I also work with my community and tell them that there are certain prejudices that the government sector stakeholders might have against us, and we are not in the same category of work that others might be. So if it's our first meeting with the government stakeholders, we want to brace ourselves to be able to answer their questions properly, understand what they are saying, and be calm and composed and say that what our demands are. It's important to have behavior change and have behavior change communication on both the sides to be able to build transparency, to be able to build bridges for better communication. And that can only and only happen when we have integrated community monitoring systems with the government systems. And
Thank you.
that brings us to the end.
Yeah, thank you very much, Kusum. बहुत धन्यवाद.
Thank you,
Thank you,
Priyanka.
Priyanka, for translating. And thank you for bringing out that component that is so crucial and which is the biggest barrier of stigma, which still exists. And we really believe in removing that. And hopefully moving forward, we can work together to ensure that the paradigm shifts, that people's mentality shifts, and that we will be able to accept communities as valuable partners. Thank you. I'd like to move on now to Iman from POP TB, which is the National Coalition of TB Survivors in Indonesia, and to talk about why it's important for the community to be involved in monitoring from the Indonesian perspective. Thank you very much, Iman, for joining us. Please go ahead.
Yeah, thank you, Bless. Should I present? Oh, okay. Thank you, Priyanka. Yeah. Hello, everyone. I'm Iman from POP-TB Indonesia. It's the national network for TB survivor organization. And at this moment, I'm the program manager for POP-TB. So about the community monitoring in Indonesia, I just will share a little experiences by POP-TB and other our member organization. Next slide, please. Yeah. Since POP-TB established in 2016 by several TB survivor organizations, so we committed that we will to increase the organization capacity member of POP-TB in terms of advocacy, organizational management, and basic need in assisting TB patient on actually TB patient on the treatment. Yeah, and we also conduct the community-based advocacy and increase access of TB patient to friendly treatment or medication, and increase access of TB patient and other affected community to affordable medicine. At this moment, we have a program. We conduct a project for reducing stigma and discrimination, and also human rights, mental health, and gender issues for TB survivor organization. So we expected that they will share their knowledge to patient that facing or experiences stigma and discrimination, etc. Next, please. Yeah, and this is how what community done in community health monitoring. Mostly is the basic thing that TB survivor organization done is assisting TB patient in hospital for treatment initiation. Unfortunately, that peer support or peer patient supporter in assisting for TB patient, not at the beginning when the patient diagnosed by TB, DRTB, then they will call peer support in the middle of their treatment. And the others is monitoring or follow up patient on treatment regularly, including side effect, drug side effect, mental health issues, etc. And conduct patient gathering, including group discussion that involve patient families to share knowledge and skill, and knowledge and skill to families is important. How to assist their family during the treatment. And community also doing the home visit to monitoring the patient and contact tracing in certain condition if there's have lost follow-up patient. Mostly they will contacted by hospital to have looking for the patient. Next. Yeah, and the other is POP-TB also help to provide basic needs like rice and any other food, nutrition, including vitamin, provide hand sanitizer and face mask. We 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 provide by contacted with the charity organization and ask them to have TB patient to get better nutrition and basic need that patient TB need. And also we for TB at this moment provide egg shelter. This is to support patients that who live far from the hospital, referral hospital actually, because in Indonesia the PMDT hospital for drug resistant TB is not available in every district. So the shelter is very important for patients to get closer with the hospital. And during the COVID-19 pandemic, POP-TB also provides smartphone for 200 TB patients and 20 peer support for treatment monitoring. And this is one of a response of our survey of study that mostly TB patients during the pandemic need the smartphone for treatment monitoring. So we ask CCM and GWG to help us to provide a smartphone that patient needs. And the other thing is how we conduct the monitoring is we also initiated the community-based monitoring and feedback by mobile application that we call One Impact Sehat Indonesia, is to provide the how TB patient experiences stigma and discrimination, for example, or violence or any other. Hello, can you hear me?
Yes, Salman, please go ahead.
Okay. Okay. Yeah. The last thing is CBMF. I would say that the mechanism is to provide how community-based monitoring and to provide feedback from TB affected community or the patient. And this is an example. This is our Facebook group for named that TB-MDR Indonesia is to provide sharing knowledge with TB patient, doctor, and other TB survivor in monitoring and sharing experiences during the treatment. That's it. Thank you, Lesina and Alkana. Yeah.
Thank you so much, Iman, for bringing that perspective from POP TB. And I think it's very, very important to understand from TB survivors as well. And we're running a little short of time, so I'm going to move on very, very quickly to invite Paran, who is part of PETA, which is the MDR TB Survivors Network, again in Indonesia. And GCTA has had a very long relationship with Indonesia and has, kind of supported and continues to support groups in Indonesia, the survivor groups. And I'd like to call on Paran. She is also the community representative on the Regional Green Light Committee and is a survivor herself. So Paran, welcome. Thank you for being here. Please share your thoughts with us. Thank you.
Thank you. Thank you, Mrs. Blasey. And hi, everyone. My name is Paran. I just like Mrs. Blasey has already mentioned that I came from Indonesia, and I'm a TB survivor for twice. And after I finished my DRTB treatment, I joined with PETA. It's patient organization in Indonesia, in Jakarta, actually. And I also want to say thank you to Global Coalition of TB Activists for inviting me as one of the speakers in the community connected. And maybe I will gonna start my presentation. Hello. Can everyone hear me?
Yes, please go ahead, Paran.
Okay. It's maybe first of all, I would like to introduce PETA to all of us in here. So PETA is a real tough fighter in Jakarta. It's community-based of DRTB survivor organization, and it's established at 15 March 2012 and as legally registered at November 2014. And our aim is to support the successful treatment of GRTB patient by providing support to the patient and the family also. And we are one of the member of POPTB, or national level patient organization. Okay, next slide. Okay, this is our vision. PETA is a professional and successful organization enrolled to help provide effective and efficient psychosocial support for the RTB patient and TB suspect and patient, especially drug-resistant TB in DKI Jakarta, and reducing rate the RTB infection in community. And our mission are increasing psychosocial support for TB patient, especially for the RTB, looking for the new innovation in developing the organization program, making efforts to obtain sufficient funding source for the implementation of program, developing partnership with other civil society organization and other government organization. And our activity is not that different from the POPTB actually. We have hospital visit where we have meet with the patient from the patient is suspect until the patient is on the treatment. So we have like motivate, educate the patient and also the family in the hospital. And then when they already transferred into the primary health care center visit, we do that. We do the motivation and education also in primary health care center visit, and we also like looking for if there's any challenge that patient have in the primary healthcare center visit. And for the home visit, we home visit all the patients that are refusing to start the treatment, or refusing to continue the treatment until cured. So we have that home visit, also educated them, motivated them, and also once again with their family. And we have focused this group discussion. We get involved in all of the stuff, and like the patient, the family, the health worker, the doctors, and everything. And we also have the patient gathering, and we also the government also invite us and included us as a expert patient trainer. And now we have collaboration also with POP-TB in patient supporter, which is me, is one of the patient supporter also now. And we also as a facilitator, and PETA also collaborate with another CSO to nutrition package distribution. And the last is we also ask the resource person. Next slide, please. Okay, this is the PMDT in before this. Okay, so this is the PMDT situation in PMDT in Indonesia. So PMDT started in 2009, and 2 DRTB treatment centers, 988 DRTB rapid diagnostic center, and 282 DRTB treatment center on 2020. The ambulatory care treatment continue decentralized to primary health care center, or we call it in puskesmas. And all oral DRTB treatment, both short-term and long regimen, is now available in line with the WHO latest recommendation. Patient supports monthly. We have patient support like monthly enabler. It's like $15 in a month, and physical social support from CSOs, like including like the one I already mentioned, like counseling and home visits, and treatment body and gathering, and 17 ex-patient group available in 14 provinces, providing psychosocial support to the RTB patient under a network of POP-TB. And the challenge is still enrollment rate and treatment success rate. Now for community lead monitoring experience from the field. In general, no direct mechanism exists for TB community to report the situation yet. The feedback is still done through informal mechanism to district or province or NTP official, or through patient support organization and representative in CCM. CBMF mechanism has been initiated since 2019. And we have the challenge identify like a lack of self-confidence of TB patient or survivor, and lack of knowledge of standardized of TB or DRTB treatment, the social cultural behavior of patient to clinician or health center, and direct formal forum for community to report the result of their monitoring, nor feedback, or CBMF is still on expansion process. So next slide, please. Okay, this is all the challenge that we face during the COVID-19 pandemic. So TB care, one of the main problem is the main challenge is TB care, the activists are significantly reduced. The RTB hospital, because of the RTB hospital and clinician are focusing on COVID-19. And TB patients are afraid to go to the hospital for regular checkup, baseline tests, and extra. The DRTB patient inpatient ward are deploying to COVID-19 isolate ward, And the RTB patient have to refer to the RTB hospital, even though it's still not enough. And the transportation to TB services is limited because of we don't have the lockdown in here, but still we have the limited activity that government wants us to, like, if you don't have to go to somewhere places, they just stay at home. And because that the transportation is a little bit more hard to get when this COVID-19, and TB less prioritized than COVID-19. Yeah, we all know that for the funding for the the hospital and the others, it's it's like we left behind actually from COVID-19 right now. And the community activities were done mostly through the virtual or other communication channels. Like Puskesmas Health Care Center give limitation to community to face-to-face visit during the pandemic, reduce COVID-19 transmission risk. And I know that the TB services is not locked down yet, not locked down, and it's open. That's the good thing. The best thing from Indonesia is our government is not stop all the TB services, but this for the communities a little bit challenge because with virtual or other communication channels, it's difficult to like, we want to have the motivated or educate the patient not face to face, because they can still, if we use like telephone, they still can reject our telephone, they not pick up the phone, or maybe because of the problem of the connection. That's actually one of the challenge. But we also have another way to know that even though the medicine is we give the medicine and you can take it in the home, but we still can monitoring them with, they have to we made a WhatsApp group that it's in it, like primary health care workers and the civil, the TB survivor like me, a patient supporter, and then the patient, and then the family of the patient. So every time they took the medicine, they will gonna upload a video, so we can know that, okay, you take the medicine. That's where we also monitoring the adherence of the patient during this COVID-19 pandemic. Next slide, please. Hello. Okay, thank you. This is our opportunities. POP-TB and or PETA as TB survivor representative members in CCM in Indonesia. Yeah, we have 3 of our TB survivor that now include in CCM. It's one of it is Mr. Budi, and PETA member as member of RGLC South Asia region. Yeah, it's really an honor for me for join as a member of RGLC South Asia region until 2022. And I also it's an honor also because I also since 2018 I become the member of Global Coalition of TB Activists. So yeah, it's really such an honor. And improving knowledge and awareness of TB patient through social media or other channels, because now it's pandemic, we cannot do face to face, so we just kind of turn it to the social media for the rising TB awareness and improving the knowledge of TB patient. And now with POP-TB also and with Stop TB Partnership of Indonesia, we expanding use of CBMF application. We give the we give the patient for more easier to what we call it in English, to they have so easier to they challenge, I mean to give the challenge right back to the CBMF from through the application of CBMF. And then government commitment is very high for TB program. President decrease on process, prudential decrease of process, increase the role of community partner and other related multi-sector for TB elimination is part of the country TB elimination strategy 2020 until 2024. Support for TB patient from other department other than health sector, because we know that TB is not belong to the only Ministry of Health, but it's belong to other multi-sector holder, and it's, yeah, we have to unite it for TB. And TB patients are eligible for government support. And collaboration and partnership between TB survivor groups with PR or SR or SSR or other organization. And monitoring mechanism by community is already showing impact in HIV and AIDS program, because they're already running it. And based on that, I'm sure that the CBMF is also can be successful to show to see how the challenge and how we can solve all the challenge for TB patients. And okay, this is my last slide. This is our control strategy 2020 and 2024. We have 6 strategy, and in strategy 5, it's increase the role of community partner and other related multi-sector for TB elimination. So it's clear that the role of community it's already already put in TB control strategy in Indonesia. So I think this is the last presentation for me. And once again, thank you to all the participants in here. Thank you so much.
Thank you, Paran. That was very good. And thank you for sharing those challenges from the ground. And also, to not just talk about the challenges, but also you've given us some opportunities. And I know POP, TB, and PETA are doing amazing work. And you said it's an honor to be a GCTA member, but actually for us at GCTA, we are honored to have you all as part of the GCTA family. And I think we can achieve great things as we move ahead. Now, last but not the least, I am really delighted to welcome a dear colleague and friend, Safar. Namaste, Safar, and welcome to this session on community monitoring. Safar is a great TB advocate. He has been one of the early, kind of drivers behind GCTA. And he is from Tajikistan, and they have actually done a lot of work in community monitoring. So he can actually speak to us from the experience of the ground level of implementing the monitoring program. So over to you, Safar. Thank you very much for joining us.
Thank you very much again. Namaskar, dear Blessina. Really happy to see you, and really happy to see all the colleagues in this session. And I'm elated to be here speaking of my experience in the country. But at the same time, thank you very much, the colleagues, for sharing the experience and the knowledge from the ground, from their ends. And this is really helpful and really enriching this content. And thank you. It was good to hear also Hindi in this session, one of my favorite language. As the MDR TB survivor myself, and having TB in my family for about 10 years, I came into TB and joined the colleagues, the wonderful people working on TB World since 2014. Since then, I became a member of several platforms, including GCTA, and a proud member of GCTA, Global Coalition of TB Activists, and the wonderful colleagues in it, and also member of TB People, global network of people affected by TB. And also I'm board member of TB Europe Coalition. We grew from 2014 as a Stop TB Partnership Tajikistan with 76 people with experience of TB and NGOs working on TB, coming together to build this multi-stakeholder platform in July 2014 in Tajikistan. Since then, we grew into building partnership with different stakeholders, and especially the government structure, starting from National TB Program, and later on introducing ourselves and associating with everyone who speaks TB. And today we are, as a coalition, as Stop TB Partnership Tajikistan, several subdivisions, I would say, group of volunteers, group of national celebrities, and a group of also some of the key NGO drives behind important decisions. And we became also, I myself become member of CCM since last year, and we are also focal point of National TB Caucus parliamentarian groups working on TB. This period since 2014 was the period that we built friendship. It was period of sharing testimonies, feelings, as Blesina correctly mentioned, that these are fine, but we need data, and we need some tools to enable us to have the data and to bring it on the table with friends. So the friendship was the core principle in our platform. It was within formal and informal meetings with either deputies and parliamentarians or CCM colleagues or any other decision makers. Well, with NTP, we were kind of, from the beginning, we were friends, and we were like from same color and speaking same thing. So in here, it was importance of having the tool to have data. So in this slide, I have problem statement, pandemic-related challenges, human rights data gaps, and engagement gaps. So as in most of the countries today, people are isolated with TB at homes, and they don't have interaction with health facilities, doctors being busy, overloaded, and the people with TB have to travel once a month or once in 2 months to get their medications from the TB centers without insufficient protective measures, actually. So plus the anticipated crisis economically and socially and etc. on the COVID impact itself, and the nutrition was problem, and it will be a bigger problem. So in the background, there has always historically been problem of data on human rights barriers not being systematically collected, and real-time data on human rights barriers were not reported. And in the engagement gaps, people with TB were not meaningfully involved in all the programmings, and they are right holders but do not know therefore and do not claim their rights. So duty barriers are unaware of the link between human rights and TB, and there is no accountability mechanism. So these were like some of the problems. And we had with the spread of COVID in my country, early in March, we had a meeting with all the stakeholders, TB stakeholders, with the NTP at around National TB Program, to prepare ourselves better what to do and how to be protective for TB program and what we can do. And there we built a COVID-19 spread response operational plan, which includes several concrete actions each stakeholder had taken up. And suddenly we were asked to take up the tool that once we started the community monitoring tool, the One Impact that everyone were aware in my country of, because we were proudly, today I say always that we were the first to pilot that tool, that in 2016 and 17, we had mapped services, gaps, etc. And we had these wonderful tools from Stop TB Partnership to do that, but also we joined that effort with other community members with Stop TB Partnership Geneva to develop this platform, One Impact, with technical support from Dure Technologies. And we piloted this and we shared some of the examples. That is like more or less and what the colleagues have already shared within this discussion. And so then there was problem of funding in between to take it forward. For one is like a continuation, second like scale up that was necessary as understood by everyone, but there was lack of funding in between from 2017 till the COVID, when again, like this has come to be an urgent activity to be implemented, and some funding has to be in place to do this. And the next slide I have, if we go to next slide, we have, with thanks, we got this financial support from Stop TB UNOPS and technical support from Dure Technologies, a couple of months till now to enroll it and to make some cases with updated version that we worked till now, and strategic guidance from NTP program, from National TB Program. And as a technical working group member, we were able to put this need into 3 strategic documents. One in NSP, National Strategic Plan for 21-25 in my country. We managed to consider some funding for this opportunity to run this community monitoring. Second, in the Global Fund proposal, that's again from 21 to 23, and in the transition plan from Global Fund to national funding. So these 3 strategic documents considers already the work of community monitoring. Again, as Blesina initially at the start of this session alluded to the fact of partnering with government, and this is important. As we said, this is not, as you rightly mentioned, policing or pointing out to the government, but this is working together. As I say, this has always been like hearing or knowing or understanding in papers, but not really seeing what is it in terms of, evidence-based. So that's the importance of first building this understanding and friendship so that you have all in the same page when we do this monitoring. So in next slide, here in this map, I showed that we started some activities these days actually in one of the most populous area of my country. As you see, we are 93% mountainous. So we started this red line is isolated areas where we started actually running the One Impact for the community monitoring. So in next, this is like the main features, get knowledgeable, into which we fitted also information about COVID-19. Also, we managed to partner with HIV and hepatitis colleagues to put some content into what we have now. When you go into get knowledgeable, we have TB, then COVID, then HIV and hepatitis. So with content in it, text, video, audios, and necessary materials into get knowledgeable. So it's for any community member, but also, I mean, for everyone in terms of understanding the disease. And in Get Access, it's like near me services available. In TB, we're also working on including HIV as well into this feature. And Get Connected, where people can interact with the peer-to-peer, but also public forum and connections with the people with TB and the response team, which in this case we had a formed group of our community members, but also some doctors and psychologists, and doctors are from NTP as response team to work on the data in the dashboard and resolve cases that are risen by people, but also feed our advocacy messages. And in the next, we have get involved. So that's again, people raise issues. And so, yeah, so it's about empowering people with information about TB and services and ways to connect to virtual TB community and empowering people to report barriers. And in next slide, please. So it's illustration of how it works. So services, affected communities, and our support groups, community health workers on the ground. So we have our organization as accessing the dashboard, working with data, feeding our advocacy, but also for national TB program for programmatic planning and action. So that's about accountability framework. So in the next slide, I put, let's go to here, some of the lessons that, as I said, when we started some of the piloting of this tool, later on the colleagues from several countries in my region managed to already work and implement and collect data, and with StopTB partnership improve some features and make this tool better tool. And here are some of the lessons learned from mine and other countries, and several of the colleagues from, I mean, within a project, what we have TB Rep that's within the region, post-Soviet countries, basically into this, and so managed to run the community monitoring. So here we see One Impact provides opportunity to have national multi-stakeholder dialogues on TB, on human rights, which is very important. And One Impact community-based monitoring model offered genuine opportunity for affected communities to engage with healthcare workers and NTP representatives and people affected by TB to inform and evaluate the TB response, as mentioned, and empowering people so that they know their rights, and which is a key component of the community-based monitoring intervention, and ensuring rights and protections of populations engaged in the pursuit of monitoring is an ethical and programmatic imperative. So mitigating risk to data piracy and security is, in this case, crucial. So the One Impact platform is flexible and can be adapted to meet local needs. such as language. In our case, we have my main Tajik language, but also minority languages, Uzbek and Russian as well. So data storage, privacy and confidentiality. So these can incorporate any issues under the framework. So we have M&E framework, which provides visibility on the progress. So we are, I mean, this is my last, in the last slide, I have thanks to all of you, and we would be really excited to share some of the data as we progressing from now till some months ahead. So again, thank you very much for your sharing experience and knowledge, and hope mine is also useful for you. Thank you very much.
Thank you. Thank you very much, Safar. It is so much. I wish we had just 2 hours for you to learn about what you have done. So it's been, friends, it's been such a valuable session, but unfortunately I'm getting messages from the union saying that we are overshot. But thank you very, very much from the bottom of my heart, on behalf of the team, for sharing your valuable, valuable inputs. I hope we can keep having this conversation even outside of this session and help and support each other so that we can move towards those very ambitious targets and making ending TB a reality. Thank you very much. Have a great day.